The Holmium YAG laser, operating at a wavelength of 2.1 microns, provides the urologist with another useful tool for laser lithotripsy. Surgical lasers operating in the mid-infrared and far-infrared wavelength have a higher exhibit more superficial, predictable effects on tissue, and do not require pigment for absorption. While the neodymium YAG laser operating in the near-infrared wavelength penetrates 5 to 6 millimeters into tissue, the Holmium YAG laser, with nearly twice the wavelength, is fully absorbed in only 1/2 millimeter of tissue. Although the Holmium YAG laser has an affinity for water, it creates a vapor tunnel during each pulse. The Holmium energy rapidly vaporizes any fluid within the 3 millimeter tunnel surrounding the fiber tip, allowing energy to pass through this corridor to impact tissue within the 3 millimeter space. While the urologist may choose many effective options to fragment urinary calculi, such as shockwave lithotripsy, electrohydraulic lithotripsy, ultrasonic, and pneumatic lithotripsy, each method has its unique risks, benefits, and limitations. Stone identification prior to lithotripsy will determine the outcome of pulse lithotripsy. In contrast, the Holmium YAG laser is essentially colorblind in the fragmentation of urinary calculi. Even hard stones such as cysteine or calcium oxalate monohydrate may be successfully fragmented even after failure with other modalities such as shockwave lithotripsy. Eyeglass protection for the Holmium YAG has the advantage over the pulse dye laser since there is no inhibition of vision during lasing when compared to the extreme flashes of light associated with pulsed lasers. A 56-year-old male presented with a large 9 by 6 millimeter calcified stone impacted in the distal right ureter, causing hydroureteronephrosis. The tip of the fiber is centered in the lumen of the visual field. A red helium neon coaxial aiming beam with the invisible Holmium YAG wavelength ensures visibility and precise placement of the fiber during lasing in direct contact with the stone. Preliminary experimental studies have demonstrated successful stone fragmentation with laser settings of 0.5 joules per pulse and frequency of 5 Hertz with only submucosal coagulative necrosis of the adjacent ureteral wall. In treating this patient with a very hard calcium oxalate monohydrate stone, it was necessary to raise the dosage to 0.8 joules per pulse in order to achieve satisfactory fragmentation. The Holmium YAG laser stone fragmentation occurs in a drilling fashion with the release of a fine spray of stone fragments. Note the presence of the guide wire to maintain orientation during ureteroscopy. One must keep the fiber tip away from the guide wire to prevent injury of the fiber tip or ureteral wall. Lasing should begin only when the stone is centered in the lumen with the fiber clearly in contact with the surface of the stone. A gradual reduction in stone volume is accomplished with a combination of drilling and sculpturing to produce a honeycomb effect on the surface. The integrity of the stone weakens as the various drill regions become confluent. Fragile break points result in stone fragmentation. A slower destruction of stone size avoids excessive movement during laser activation with less risk of stone migration. Perforation of the adjacent ureteral wall may occur if the surgeon loses sight of the fiber tip as it drills through the stone. It is much safer to work at multiple sites at the surface of the stone until large fragments are converted to smaller, passable sizes. A double J stent was placed over the guide wire at the end of the case to facilitate urinary drainage and reduce edema in the early postoperative period. The patient was discharged on the day of surgery. The stent was removed in the office 72 hours later. A comparison of the Holmium YAG versus pulse dye laser lithotripsy will help to summarize the different features of both techniques. Rather than the hammer-like effect and the bright flashes of light associated with the pulse dye laser, the Holmium YAG laser produces a spray of calculus material with minimal bleeding and less propulsive migration of stone particles. The Holmium YAG laser fragments stones independent of color or composition, whereas the pulse dye laser has difficulty breaking very hard stones such as cysteine or calcium oxalate monohydrate. The pulse dye laser may be less traumatic directly to the ureter, but the Holmium YAG will only cause ureteral injury during improper dose selection or inadvertent proximity of the fiber tip to the ureter. While use of the pulse dye laser is mainly limited to stones, the Holmium YAG laser is a versatile, multifunctional device which can not only effectively fragment ureteral calculi, but also can ablate soft tissue pathology throughout the urinary tract.